Welcome to our video on uterine rupture and other etiologies of antepartum hemorrhage. Let's get started. Here is our overview slide. Let's begin by discussing uterine rupture. With regards to this topic, we'll be discussing the definition, risk factors, classifications, clinical presentation, diagnosis, management, and prevention. Let's begin with the definition. Uterine rupture is a life-threatening pregnancy complication where the uterus essentially ruptures. Note that uterine rupture most commonly happens during the delivery process itself. Risk factors include factors that result in uterine scarring and distension. Examples include previous uterine surgeries such as C-section and myomectomy, fetal macrosomia, which can cause uterine stretching, uterine anomalies, and induction of labor or prolonged labor. Trauma such as motor vehicle accidents may also induce uterine rupture. Uterine rupture presents as acute onset severe abdominal pain with cessation of uterine contractions and loss of uterine pressure. Highly suggestive findings include loss of fetal station, palpable fetal parts, and fetal distress. It's important to note that bleeding can be intra-abdominal or vaginal. Patients with intra-abdominal bleeding will present with signs and symptoms of hemorrhagic shock, such as tachycardia and hypotension without evident bleeding as the bleeding is internal. Some patients may also present with vaginal bleeding, and if this is present, it can range from spotting to severe hemorrhage. Here's an image from our partnership with AMBOSS, which shows complete uterine rupture. Complete uterine rupture refers to rupture of all uterine layers, including the visceral peritoneum. The rupture leads to life-threatening massive intraperitoneal and vaginal hemorrhage. Here are some other images from our partnership with AMBOSS, which shows a uterine scar and concealed uterine rupture. In the image on the left side, we can see a uterine scar that predisposes to uterine rupture. On the image on the right, we can see what can be referred to as uterine dehiscence, closed rupture, or concealed rupture. In this type of uterine rupture, there is no connection between the uterus and the peritoneal cavity, and no intraperitoneal hemorrhage occurs. This is in contrast to complete uterine rupture that we saw in the previous image. Sometimes, signs of imminent rupture may occur before the complete uterine rupture. These symptoms include maternal agitation, hyperventilation, and tachycardia. Okay, moving on to diagnosis. Uterine rupture is a clinical diagnosis that should be highly suspected in patients with the classical presentation we just discussed. Fetal heart rate monitoring will reveal evidence of fetal distress, such as decelerations. In case of complete uterine rupture, emergency laparotomy with C-section is required. In case of imminent rupture, IV tocolysis and emergency C-section can be done. Planned C-section prior to onset of labor is indicated in patients with uterine dehiscence to prevent full-on uterine rupture. Finally, hysterectomy can be done in case of refractory bleeding. To prevent uterine rupture, the patient's history should guide the delivery method. Patients with a history of low transverse C-sections or myomectomy without entry to the uterine cavity may attempt vaginal delivery. In patients with a history of classical C-section or myomectomy with entry to the uterine cavity, vaginal delivery is contraindicated. All right, let's try a question. A 32-year-old woman at 32 gestational weeks comes to the physician for routine prenatal examination. She has a history of 2 previous cesarean sections, one of which was an emergency C-section. Her medications include insulin for gestational diabetes. She is a smoker, but she has not smoked since she discovered she was pregnant. What is the most important risk factor for uterine rupture in this patient based on her history? All right, so this question mentions a few conditions and asks us to identify the most important risk factor for uterine rupture based on the patient's history. So let's recall together the risk factors for uterine rupture. These include factors that cause uterine scarring and/or distension. So examples of this are previous uterine surgeries, such as C-sections or myomectomies, as well as fetal macrosomia, which can cause uterine stretching, uterine anomalies, induction of labor or prolonged labor, and trauma. However, the most important risk factor for uterine rupture is having a uterine scar, especially after an emergency C-section where the incision is vertical. All right, let's move on to our next topic, other etiologies of antepartum hemorrhage. These can be obstetric or non-obstetric causes. Obstetric etiologies include stillbirth and bloody show. Non-obstetric causes include cervical trauma. Let's discuss the obstetric causes first. Stillbirth presents as vaginal bleeding with crampy abdominal pain that occurs after the 20th gestational week with uterine contractions and cervical dilations. Bloody show presents as bloody mucus vaginal discharge with a dilated cervix. This signals the onset of normal labor. Important features of bloody show include the presence of a small amount of blood-tinged mucus, regular uterine contractions, and the absence of pain. The other etiology of antepartum hemorrhage is the non-obstetric causes, which I discussed earlier, so cervical trauma. This can occur during sexual intercourse or birth. Patients typically have a positive history of a possible inciting event. Exam will reveal a tender, bruised cervix without signs of active bleeding. Here is a table that summarizes the conditions we've been discussing in this lecture. Feel free to pause the video and take a moment to review. All right, let's wrap up with a final question. A 28-year-old G1P0 woman is brought to the emergency department at 37 weeks of gestation by her husband due to rupture of membranes. She has progressively intensive uterine contractions every 2 minutes. The cervix is dilated at 5 centimeters. She has a past medical history of poorly controlled type 1 diabetes mellitus. An ultrasound reveals polyhydramnios. 6 hours after the onset of labor, she experiences sudden worsening of abdominal pain. The fetal station returns from +1 to -3. The patient's vital signs include a blood pressure of 60/40 millimeters of mercury, a heart rate of 140 beats per minute, and a respiratory rate of 24 breaths per minute. Cardiotocography reveals recurrent late decelerations. IV fluids are administered. Which of the following is the best next step in the management of this patient? A. Emergent C-section. B. Planned C-section after 24 hours. C. Emergent vaginal delivery. Or D. Planned vaginal delivery after 24 hours. All right, this patient is clearly in labor. She was diagnosed with polyhydramnios, likely due to her poorly controlled type 1 diabetes mellitus. 6 hours after the onset of labor, she experiences sudden worsening of abdominal pain, and the fetal station returns from +1 to -3. Additionally, she is hemodynamically unstable, and the fetus is experiencing hypoxia as evidenced by recurrent late decelerations. All of these findings are consistent with the diagnosis of uterine rupture. Uterine overdistension by polyhydramnios possibly predispose the patient to uterine rupture. So the best next step in the management of this patient is emergent C-section. So the correct answer is option A. Here's a slide reminding us of the management of uterine rupture. Recall that in cases of uterine rupture, emergent laparotomy with C-section should be performed immediately. Option B, planned C-section after 24 hours, is incorrect because both the mother and the fetus are hemodynamically unstable and immediate intervention is warranted. Options C and D are also incorrect because vaginal delivery is time-consuming and potentially lethal for both the fetus and the mother in case of uterine rupture. So again, the correct answer is option A, emergent C-section. And that concludes this section.